Welcome to the recorded version of Disaster Preparedness for Community-Dwelling Older Adults with Dementia and Caregivers, Key Design Elements and Lessons Learned from a Health System Pilot, from July 10, 2018. Part of the National Alzheimer's and Dementia Resource Center webinar series, sponsored by the Administration for Community Living.
Great. Thank you so much, Steve. Welcome, everyone, to the webinar today on disaster preparedness for community-dwelling older adults with dementia and their caregivers. In this webinar series, the Administration for Community Living's National Alzheimer's and Dementia Resource Center has partnered with the American Society on Aging, and we're pleased to have all of you in attendance today. Just a quick note, we don't have to wait until September 12th to have you all again at a webinar. We actually have another webinar on July 31st on health disparities in people living with and at risk for dementia. You can find registration information about that webinar on ASA's website. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hi, everyone. Thank you so much for taking the time out of your busy schedules to join us to learn about this very important topic of disaster preparedness. We're excited to learn what Nancy Oliva and Betty Wexler are going to tell us about their work in California and with the VA. ACL is excited to bring this information to you, and with that, I will just send it back to you, Sari, so that we can get things rolling. Thanks again.
Great. Thank you. So as you heard, for today's webinar, we'll hear from Nancy Oliva, who is a health services researcher, educator, and consultant affiliated with the University of California, San Francisco Institute for Health and Aging. We'll also hear from Betty Wexler, who's a clinical nurse specialist in geriatrics with more than 30 years experience with older adults in medical, surgical, home care, hospice, and clinic nursing. Betty Wexler retired in 2013 and now is a consultant. So I will turn it over to Nancy and Betty to start their presentation, and we will save the end of our time together for questions and answers. So I'll turn it over to you.
Well, thank you very much for inviting us to give this presentation on a subject that's very important. I do want to add that the opinions expressed in this presentation are those of the presenters and do not necessarily reflect those of the Veterans Health Administration. We'd like to talk briefly about the fact that older adults are vulnerable to natural disasters, and many of us are familiar with those in the recent past and somewhat more remote past. And here we have a satellite picture of Hurricane Katrina. That was in 2005. 70% of the estimated 1,330 victims in Hurricane Katrina were over 60, though they comprised 15% of the area population. Most died in their homes and in the community, with 68 dying in nursing homes. What is very important to learn and to know is that there are a growing number of disasters and emergency events that are emerging in these states and that are alarming. The U.S. experienced the most active and expensive year on record for disasters and emergency events in 2017, with total economic damages exceeding $300 billion. Hurricane storms, floods, fires, and extreme temperatures touched every region of the country, causing requests for disaster assistance to increase tenfold over 2016. Threats to health security are increasing, and health security is a concept that has evolved fairly recently that is a measure of the ability of communities and states and regions to keep people healthy and safe in the presence of emergencies and disasters. In 2017, the Gulf Coast hurricanes disaster and Irma occurred, and over 80 deaths occurred each in Texas and Florida as a result of the weather emergency. In Puerto Rico, we've heard a lot about the tremendous impact that Hurricane Maria had. There's a question about the exact number of deaths, but it appears that at least 1,000 deaths did occur as a result, directly and indirectly. And more recently for us and closer to us in terms of Northern California wildfires of last fall, at least 44 deaths occurred in 4 counties. And the average age of those dying was 79 years of age. In our state, in January 2018, Santa Barbara, the Santa Barbara community, Montecito, experienced floods and debris flow, mud flow, as a result of fires in the hills above Santa Barbara. 21 deaths occurred, including 9 older adults, age 60 and over. In terms of the Santa Barbara floods, and to the left you see a picture of a cottage that was inhabited, that was ejected from its foundation into a tree in the community. The mandatory evacuation orders in those floods focused on an area in which 7,000 people were living. And this is, again, important information in terms of the demand on local agencies for help. Local agencies received 600 calls for help between 3 a.m. and 6 a.m. at the time of the worst debris flow from individuals and families trapped in their homes. That's 3 1/3 calls every 60 seconds over a 3-hour period. 1,000 people were subsequently rescued. 300 people were still trapped in homes days after the debris flow and flooding. Again, a reminder of how important preparation for a disaster can be for those living in communities, particularly older adults. This is a slide which displays the mix of ages one finds in an Alzheimer's dementia population. This is from the Alzheimer's Association. And you see under the blue slice of the pie, 85 people 85 years and over, comprising 37% of all people with living with Alzheimer's. And again, the purple slice relating to 75 to 84-year-olds. Together, those comprise 80% of the Alzheimer's dementia population in the U.S. 16% of those living with Alzheimer's are 65 to 74. This slide talks or addresses Medicare claims data, and it does indicate that 1/3 of all Medicare beneficiaries who die in a given year have been diagnosed with Alzheimer's or another dementia. On the right-hand slide, right-hand part of the slide, you see a projection for the number of people expected to be living with Alzheimer's between 2000 and 2015. You can see at around 2030, there's an increase in the purple section relates to those 85 and over. It's going to be a significant increase in those with Alzheimer's who are aged 85 and over. And by 2050, rather, we see that we have close to 12 million individuals with Alzheimer's living, most of whom are living in the community and will continue to live in the community if you're a lower percentage are institutionalized. As we know, and as we've just discussed, there are disaster response risks for older adults without dementia, even though we're focusing on dementia, and I wanted to mention those just to make that point. And risks are present for those with mild cognitive impairment, which is separate, as we know, from dementia, may precede to dementia. The American Academy of Neurology estimates that 15% of people age 60 and over have mild cognitive impairment. In 2018, that percentage equals 11.6 million people. Again, MCI is not dementia. It's characterized by a couple subtypes. Amnestic MCI, the primary symptom of which is memory loss, and then non-amnestic MCI, which primarily impacts thought processes, which of course has implications for disaster preparedness and evacuation and response. Thought process impacts include symptoms such as changes in judgment, planning, decision-making abilities, and even visual recognition, the ability to visually recognize images and people. So again, MCI can impact older adults' reaction to and functioning in response to a disaster and in evacuation and or recovery. And I wanted to mention this again in passing. We're talking about dementia, and I just talked briefly about MCI, but there's some changes that occur in cognitive aging, which is normal. All of us experience that as we age. And cognitive aging can impact and does impact older adults 60 and over. And changes can manifest through one or more of the following: reduced processing speed, changes in judgment, planning, decision-making, problem-solving, learning, and memory. And again, as you can imagine, even though this is cognitive aging, which for all intents and purposes is considered a normal part of aging, there can be challenges for those people who age. All of us will do that, or we are experiencing some of these changes. And it's just something to keep in mind when you're providing education to seniors who are not demented necessarily or do not have MCI. It may have some challenges, too, in disaster response, so it's something to be mindful of. I put this slide in here just as a reminder of some of the limitations or challenges for older adults who have dementias or dementia, and sometimes people can have several kinds of dementia, not just one. Alzheimer's is the predominant dementia. There are some challenges that people with dementia may experience, but also challenges that people with other chronic diseases may experience who do not have dementia. But those with dementia tend to, according to the slide, and this is reported by caregivers of those caring for people with dementia and those not caring for individuals, older adults who do not have dementia but other diagnoses or diseases. There are difficulty transferring or getting out of bed, dressing, feeding, and moving from or ambulating. So what we're seeing here is, again, the purple data relates to caregivers reporting that those with Alzheimer's have fairly consistent challenges in almost all activities of daily living and in functioning and ambulation. Slightly less so reported for, or challenges are reported by caregivers of older adults with other diagnoses. So it's clearly about half of dementia patients, at least on average, have difficulty moving from bed to chair or bed to standing or other functional or physical activity. Again, it's germane related to disaster response and moving out of the house and being able to evacuate effectively and quickly. This is a summary on the right-hand side of older adults when asked about the help they may need in evacuating at the time of a disaster. This is an AARP survey that was done by Harris International. Adults, about 25% of adults 75 and over report needing help evacuating, with over 2/3 indicating that they needed help from outside the household. Younger, older adults have less of an issue with needing help. And clearly younger, older adults are much more confident about their ability to evacuate than adults 75 and over. And this is a different data source, but just in summary, in the 2000 U.S. Census, 13 million adults age 50 and over reported that they would need help evacuating, and 1/2 reported that they would need help out from outside their home or residence to do so. So a summary of issues for older adults facing community disasters. And I should note that on the left, this is an image of the Oakmont community, which is a retirement community of 4,000 people in Santa Rosa, California. And as you can see, the hill above the street in the community was on fire, and actually the entire community had to be evacuated. Fortunately, only a few houses, a couple houses were destroyed. Most were saved, and the evacuation was completed successfully. When disaster strikes in communities, older adults have many vulnerabilities, and again, important to keep in mind that there are functional capacity limitations, as I just mentioned, about ambulation and transferring from service to service, and self-care. Chronic disease can complicate evacuation, and also planning or implementation of a plan should the individual be living alone, which is not uncommon among older adults. Some may no longer drive. Some may not have cell phones, or may live in areas with spotty cell service. In the case of the Santa Rosa or Sonoma County fires, and also in Napa, Lake, and Mendocino counties, a number of cell phone towers were taken out by the fire, so that interrupted cell phone service in a wide area. And a lot of people during this, the fires in all the counties in the Northern California lost power. And I think it's always safe to assume that that's going to happen in a broad-scale emergency in a community, particularly in a weather emergency. I will add this, and this is true for the Santa Rosa, Sonoma County, Napa, Mendocino, and Lake County fires. Some older adults refuse evacuation for a variety of reasons, including just abject fear, fear for their pets, uncertainty, and concerns about home security. And what I found in my study of the responses at the community level and neighborhood level for the firestorm of last fall, neighbors who can help, in some cases, were able to help because they were aware of their neighbors' disabilities in terms of either functional capacity limitations or people with dementias or MCI. There are some older adults who don't share that information or don't communicate or self-isolate and may not be connected with their neighbors. And I would say that it's an important message to carry out, and was in our own pilot, that it's important to have your neighbors, to know your neighbors and have their contact information, and have some awareness of, facilitate awareness on their part of individual disabilities and the fact that you may need help. It may be your neighbor saving you. It may not, because the fire department or the police department or sheriff may not be able to get to you in time. So that was part of our intervention, and Betty will talk about that as we talk about the project. And lastly, just in terms, again, of the casualties of the wildfires in North Bay, again, the age range of adults was generally 50 to 100 years of age. One of the younger individuals in that age group was a caregiver who made every effort she could to save herself and her older adult, and was sadly unsuccessful in doing so. Many of the victims tried to evacuate, and some were found on or near their driveways or in their garages, and some of them could not get out of the garages because the garages and the garage doors lost power, and they were not strong enough to open the doors. Again, another issue and take home to consider when you're providing education and educational intervention for older adults, caregivers. And again, lastly, 44 people in those fires died in those 4 counties, and 6,500 homes and businesses were either damaged or destroyed. Lastly, just in terms of what can happen in a quickly moving environmental disaster, the fires in the North Bay moved so quickly that the 911 system could not take care of the demand, respond to the demand, because there were a massive number of calls coming in from a widespread area and limited resources. And best intentions did what could be done to help save buildings and people. The need for earlier and more informative community warnings sent through multiple platforms like cell phones, airwaves, radios, social media, and landline warnings was suggested and is being addressed at the county levels in those communities impacted. And also, there is a need for faster evacuations. It's pretty difficult to, given the fires that occurred, it was difficult to evacuate any faster than the responders could evacuate. The fire moves fairly quickly. If you have a fire in your house, the rule of thumb typically is that it doubles in size in about 30 seconds. So Betty is going to talk to you now about the history of our project.
Hi, everybody. This is Betty now. At the time of this project at the VA, I was the clinical nurse specialist with the GREC. The GREC stands for Geriatric Research, Education, and Clinical Care Centers, and there are several of them across the nation. The concept of this disaster kit came to us as a prototype from a VA researcher who had developed this prototype. And I was co-chair of the Dementia Committee at the time, and we received a copy of a sample of a kit. And I thought this was absolutely great, so I brought it forward to the committee, and we identified that disaster kit as just a great opportunity for a quality improvement project. Everyone in the Dementia Committee, on the Dementia Committee, worked on a daily basis with veterans who had dementia and with their family or other caregivers. So we were quite aware how essential this would be. Now understand, at the time that we started this project, the key issue of disaster in California was earthquake. This was prior to all the fires and climate change we've been experiencing more recently. So our focus was going to be at the time on earthquakes. As a result of our prototype discussion, we formed an interdisciplinary committee. And what we wanted to do was to develop a disaster kit that, using a prototype as a basis, for our community-dwelling veterans with dementia and their caregivers. But as well, we wanted to provide some education along with that, because we all know just handing somebody something doesn't mean they're going to look at it, use it properly, etc. So the members of the committee, eventually the subcommittee working on the project, included myself, a nurse practitioner from Home-Based Primary Care Program, the RN director of the Adult Day Healthcare Program at the VA, a geriatrician, a RN Health Services and Gerontology researcher who is Dr. Nancy Oliva, and a health science specialist. As well, all along the way, we did consult other disciplines who were involved intermittently and to help us make the correct decisions, and those included social work, psychology, and recreation therapy. The goals of the pilot, we developed two goals. We wanted to develop and disseminate basic disaster kits to community-dwelling veterans and their primary caregivers, and understand that the primary caregiver may not be a family or identified as a family or friend, but could be someone living in an assisted living facility. We also wanted to increase caregiver knowledge regarding disaster preparedness and planning. Our outcome measures were defined as distributing 100% of the kits to targeted veterans and primary caregivers over a 6-month period, and also to increase caregivers' knowledge as a result of this preparedness education. We came up and discussed the following assumptions. We were all quite aware that disasters of all kinds affect older adults disproportionately, particularly those with special needs, and that dementia can complicate an already complicated situation and would require in preparation targeted planning and supplies, additional time and teaching and resources for those who are affected in order to help them evacuate, stabilize, and recover. That we felt individuals and their caregivers with dementia and their caregivers would benefit from guided preparation and a kit developed with their special needs in mind. That sharing contact information with neighbors is key to disaster response, and that was and known, as Nancy alluded to, was a critical issue in the recent Northern California wildfire evacuations. And in any of the community trainings now, like community emergency response trainings in various communities, at least here in California, and I'm sure elsewhere, stressed is having a relationship with your neighbors, and having their contact information. So the next steps were to designate this pilot project as a quality improvement project through the VA Palo Alto Health Office of Research, which required an application to deem that this was not research, but this was actually a quality improvement pilot. And it was approved by the Quality Management Director and the Research Office in September 2010. Along the way, we were required to keep the Chief of Staff's office up to date and apprised of the progress of this pilot. We utilized the PDSA, Plan, Do, Study, Act, a quality improvement model, which is a 4-step iterative model and proved very helpful along the way. And we did decide to measure our outcomes through a pre- and post-survey process. Initially, it came to our attention, actually it was Dr. Oliva who kind of told us about this and recommended this, that we do some casual interviews with patients that either I saw in the clinics in geriatrics or that were visited by nurse practitioners in home care or seen at the adult day health care. Just some loose kind of semi-structured interviews to ask them, find out what did they know and how engaged were they in disaster preparedness, and what did they think would be essential to know or to have in a disaster kit. So that just gave us a little idea of that we were going along the right lines, that basically nobody was really prepared. They didn't have energy under the stressors they suffered to even think much about it. And we also wanted to make sure that we address the readability of anything we provided at a maximum 8th grade reading level. So we utilized the Flesch-Kincaid readability and reading level scales. And that was helpful all along the way as we move forward. I'm going to hand it back to Nancy to talk about budget estimates and funding. And I'll be back soon.
So we should say that we identified several hundred, actually over 250 veterans who are community dwelling, non-institutionalized, who we thought could benefit from our intervention, and with them we identified an additional 278 caregivers. So that determined what our target was in terms of outreach and education, and that also then in turn influenced the non-labor costs or the supplies costs that we estimated for the pilot in terms of buying kits. We bought bags, which we labeled disaster kits, one for the veteran and one for the caregiver. And we did that because we needed information to be compiled and collected and included in the disaster kit for each of the dyad of the two. And it usually was a spouse, but sometimes other family caregiver who needed and was included in our pilot. So our expense costs, and we'll explain what we put in the kit. And we did this to make it easier for those with dementia and their caregivers. So we provided information. We estimated about $13,000, and so we did some fundraising to collect assets and resources to purchase kit components. And those donations came from veteran service organizations. And also we were able to reach out to one of our Bay Area internet entrepreneurs, Craig. Some of you are probably familiar with Craigslist. Craig Newmark actually helped us with a donation as well. And our Geriatric Research, Education, and Clinical Center, home-based primary care, and palliative care departments provided funding as well. In order to look at where people were beyond our initial sort of informal interviews, we developed a survey to survey people's knowledge, caregivers' knowledge primarily, around earthquake or other disaster or emergency preparedness, and whether or not they had a plan, whether or not they had supplies or a kit, whether or not they had contact information for their own relatives as well as neighbors, whether or not they had set aside food and water and medications and medication lists. And what we found is that although people understood and appreciated the importance of having a disaster kit or a disaster plan, most actually did not. So that sort of validated our assumption that although, again, caregivers would like to be prepared, that they have not had the opportunity to do so. So we did find that actually more people than we expected had some, emergency contact information for their family. So that was a good starting point. The educational material that we used, and we had some handouts, there were very few, again, because we were mindful of the burden that we were placing on caregivers for reading the information and rereading it and refreshing the information. We included a handout from the California Department of Aging on earthquake preparedness, which had some good pointers in it. And we also included information that's very helpful from Alzheimer's Association, and also our committee made some additional suggestions about key points to include in the written material and along with our personal intervention that the committee members did with individual older adults, either those with dementia or the caregivers. And the distribution of the kits and the educational intervention, explaining what was in the kit and, again, reminding caregivers of what was needed, was accomplished through committee staff. Again, we had people on our committee who were involved in adult day health care, in home-based primary care, home health, and social work, and palliative care. So we also, again, later, about 3 months to 6 months after we completed the intervention and distributed the kits and the education with caregivers and veterans, we did a follow-up survey that I'll talk about a little bit later. And that was indicated that we made a difference in terms of preparing caregivers for responding to a disaster and having supplies and having a kit.
Hi, this is Betty again. I want to talk about the kit development. We did spend a lot of time discussing how we would change the original prototype of the kit, and some of that came from our concerns about safety. We always came from an approach of safety. So, for example, if there was a liquid with an alcohol-based sanitizer that could be drank by a veteran with dementia, we didn't think that was a good idea. Or a necklace where someone could choke themselves with a whistle. So we changed those kinds of things. We also placed some additional items in the caregiver kits. We placed the emergency radio flashlight there and the educational information in the caregiver's kits. Otherwise, they were similar. And here's a picture of one of the educational handouts, a first aid kit, and a coil bracelet with a whistle. The coil bracelet was originally a necklace that a veteran with dementia could cause some choking if it get caught in anything, so we changed it to that. And the next page we have a sample of the flashlight kit, and we also gave them a short DVD, which was kind of comical. It was created by the American Public Health Association on the importance of disaster planning, and it was sort of a little light kind of DVD, but it certainly stressed the importance of being prepared. Here's a few other items that were included in our kit. As you can see, there's a hand sanitizer wipe, so we replaced the liquid with wipes. We gave them masks and gloves. We gave them a book and a pen, and we gave them a flashing emergency reflector that could be clipped on. If it were dark, it would indicate that be able to find them a lot easier. We also did give them guidance for addressing behaviors that might occur during and after a disaster, and also a very important photo album ID, which you're going to see on the next page. Well, you're seeing it now. So this is the booklet we put together, which we think is so essential, that identifies what the veteran and or caregiver needs to put in there. Each of them was given a book. So what we needed was to have their personal information in the book, and each sleeve of the book we put something in to tell them what to put there, which was very, very helpful. We have a local emergency contact. We encouraged a photo of the veteran, and in the caregiver's book, a photo of the caregiver, and other family or important phone numbers that they needed to have listed that they could just take with them as they went. And Nancy will talk more about that a little bit later. The other educational tool was from the California Department on Aging, which had to do with earthquake hints, tips for seniors during an earthquake. As I said at the beginning, that's what we were concerned with at the time this project evolved. We wanted to minimize learning burden, and we wanted to limit the educational handouts that we gave to people, because we know all too well what happens when people are given a bunch of papers or handouts and that are not gone over, that are endless, hard to read, at a high level of reading, et cetera, et cetera. Then we did look into behavior management guidance during an evacuation and tips for preventing agitation, and just things that the caregiver could have ready to keep that veteran entertained or not so distressed should a disaster occur. We got these guidelines through the Alzheimer's Association and some other sources, and they were considered to be very, very helpful by the caregivers and by our team. I'm going to hand the phone back to Nancy.
Much of what was on that handout on the previous slide came from the Alzheimer's Association. It's very helpful information about tips for decreasing anxiety in an individual with dementia in the presence of, disaster or evacuation or follow-up in a shelter. So the information is available in your states via the Alzheimer's Association as well. This particular one happens to be specific to Colorado, but again, fairly common core of tips and behavioral management guidelines, regardless of what state you're in. In terms of what we recommended, again, we provided some initial supplies, as Betty mentioned, and we displayed in our pictures, but we also provided guidance in our on the back of one of our two handouts and what caregivers need to add to the kits, in addition to what we had given them for both the individual with dementia, person with dementia, and the caregiver. And a gallon of water per day for at least 3 days. The common wisdom now is a 7-day supply is much better. However, there is an issue in terms of being an older caregiver and carrying 7-day supply in each of 2 bags or even 1 bag. So that's something to consider. 3-day supply of non-perishable food in paper Tetra Paks or cans with flip-top openers. Otherwise, a can opener would be needed, and that might be a challenge for an older caregiver. 3-day supply, perhaps longer, of essential medications and a list of current medications. Eyeglasses, hearing aid batteries, blanket, cash is really essential to have. Garbage bags for bagging clothes, but also bathroom use or urination or defecation in the absence of functioning systems, water or sewage. A list of, certainly we also suggested a list of activities for veteran, and that may just be having something to hold on to, like a stuffed animal or a pillow also. We also, and this is very important, instructed caregivers on how to maintain kits, and it's important to review the kit and what's in it to ensure that the expiration dates on items, specifically batteries or food items, have not passed, and to update medication lists that may be in the disaster kits, and add new medications or change the list if there are eliminations of medication. And keeping the emergency contact information current, whether it's family or neighbors. And it is important to have a contact of some kind. I think in the presence of a disaster, and this was quite true in the wildfires in Northern California as well as the floods in Southern California, to have a person you can call who may be out of the area, not affected by the disaster, who can relay information, that single point of contact to other members of your family. That's the rationale there. And again, we talked about how important the photo and ID album is, and the personal identification information album is. And again, having a picture, and that includes not only for the caregiver and person with dementia, but also pets. And we haven't talked about pets, but again, pets are a reason sometimes people choose not to evacuate. So we do suggest that that individual older adults prepare to evacuate with pets, and we recommend helping them think through that, how that's going to happen, and provisioning food for animals as they can. Certainly, it's nice to have copies of advanced health directives if they are available. Some may not have that, and that may be difficult for a caregiver who's providing 24/7 care, but that is a suggestion. And just in terms of, draw your attention to the chart on the right, we asked people initially in our 9-question pre-intervention survey, we asked them to rate their level of preparation for a disaster. And you can see the green bars are bars representing the pre-intervention answers, and most people were not prepared by self-report. The dark blue bars are post-intervention. Again, there's a variation in numbers because we lost some patients or individuals who died or were institutionalized, and so their caregivers dropped out of the post-intervention survey process. But if you look at the chart, you will see that we shifted the bulk of the pre-intervention, not prepared at all, to prepared, very, very well prepared, or well prepared from not prepared at all, and that we were pleased to see that.
We're coming up to we might have to rush a little through. This is Betty. But anyway, you will have the slides after. We're talking about lessons learned from this project, and there were many. We talked about the team members. We talked about that understanding that most people involved with pilot projects have other commitments in other parts of their role. We understand that caregivers are stressed and need clear instructions and anything clearly given to them, and that safety should be considered tantamount in anything you do. Also, that behaviors change over time, and that would mean changes to the plan to keep the veteran distracted along the journey of dementia. Follow-up may most likely be an option and will be helpful to bring people up to date and check on them periodically to see if they've updated their med list, etc. There are state agencies or local agencies that are maintaining vulnerable population registries that can be helpful. And on this page, we have a sample of one that you could look at later that would be very helpful to be on a registry. I'm going to hand it back to Nancy.
Well, I guess without saying that, just an additional few lessons learned. The project funding needs to be realistic, ongoing, collaborative, and coordinated among organizations. That can be challenging and expensive and time-intensive. One thing I wanted to add is disaster planning information from national, state, and local agencies is extensive and can be overwhelming even for those without health issues. So summarizing and simplifying some of this information in order to educate those vulnerable in the face of disasters is essential. Again, mobility issues need to be factored in, as I've stressed and we've stressed, per individual, and that certainly can vary over time. And I think it's also important, and this is true from our more recent wildfire experiences and flooding, that it's essential to speak with older adults you're working with about how they would evacuate if they had to. Which door, which place, what path, where would you go to meet up with neighbors and other family members? And again, note that individuals may refuse to leave their residence for any number of reasons. I would add that consider collaborating with social network villages, which are emerging social organizations that are attempting and developing with the express purpose of helping older adults age in place, and that are typically volunteer-powered. But villages, and there's a National Village Association as well as usually one at the state level, maintain information on vulnerabilities of the individuals, the older adults in their communities and who belong to their social village model network. And so they would be an important group to work with if you're working at a community level on disaster preparedness for those with dementia as well as those without. and with other chronic diseases. And again, it's stressed, but I'll say it again, it's important to have intermittent outreach to caregivers, dementia patients, excuse me, to ensure that they are keeping disaster kits maintained, that their information is up to date, and that they receive new instructions in terms of preparedness as new evidence arises. And in terms of research, we'll continue to look at how our preparation activities, I think, make a difference in terms of how prepared and how individuals respond to a community disaster. And again, I did talk about health security. And again, it's a concept you'll hear more about how prepared communities are to keep people safe and healthy in the presence of a national disaster, a health or a weather emergency or any other local emergency. I did want to add that the American Public Health Association has done a lot of work, and many other organizations have as well, on preparedness at a community level. There is a Get Ready Day, which refers to Get Ready for a Disaster, on September 18th, 2018. They do this every year. I put some links here, even though it refers to the flu. It's not just the infectious disease or pandemic disaster, but they provide preparedness education and resources, and a whole lot of resources for all sorts of community disasters.
Great. Thank you so much for your wonderful presentation. We have some questions coming in, and you can keep on posting those in the Q&A pod of the webinar. And while those questions are coming in, I just want to mention that in addition to this webinar on disaster preparedness, the National Alzheimer's and Dementia Resource Center is developing a disaster preparedness toolkit that will be available in the fall on the NADRC website. The Disaster Preparedness Toolkit is a consumer-focused resource guide that includes a variety of tools needed for disaster planning involving people living with dementia, their families, and others who may interact with the person who has dementia. So we have a few minutes here to get to some questions. I want to start with a question. Someone has asked, what might be done if a person with dementia refuses to leave their home when evacuation is ordered? Are there any options available to those who are providing care and first responders? Betty and Nancy, could one of you address that?
I think that that's something that you would certainly need to evaluate on a case-by-case basis. We know from our more recent experiences, particularly in broad swaths of counties where there are thousands and thousands of square miles, that the first responder may not be able to get to you immediately, or to your residence if you're a caregiver. And I think this is where being in touch with your neighbor and communicating with your neighbor really can and will make a difference in terms of facilitating that process. It can be very difficult. A lot of spousal caregivers are ill themselves. Most are chronically ill and are maybe frail. Many of them are frail anyway, so it may not be possible to actually physically compel a person with dementia out of the home. But I appreciate the excellent question, and certainly I think a first responder group, I'm fairly sure would not hesitate to physically move someone out of the home in the event of, for example, our wildfires or a horrifying debris flow and flood that occurred in California in January of this year in Santa Barbara.
Great, thank you. We have quite a few requests for the educational materials that you've referenced throughout the presentation. Can participants contact one of you for those documents if they're interested, with your contact information that's on the last slide?
Absolutely, and you can contact me. I will have images of them. I have paper copies, but I think the images would be probably easier, and that I'll send to people of all four pages.
Great, thank you so much. Can you talk a little bit about how this type of kit and disaster preparedness situation would maybe be different in a rural versus an urban area?
Well, having lived in a rural area, not currently, but for 16 years in Central Valley, resources are certainly spread more thin. Your neighbor may be a neighbor half a mile down the road, and so there are very acute and very specific challenges to that. I think given that, still, again, notifying your neighbor, but also your local fire departments, and your neighbor may be a volunteer on that fire department, that you have a vulnerable older adult, both a person with dementia or MCI, or someone with other chronic disease that limits their ability to evacuate, and that could be also the frail caregiver, and let them know that that you will need help evacuating in the event of a wildfire or other natural disaster or emergency. I think more counties and more communities are investing time and resources in allowing people to sign up, in a vulnerable adult or vulnerable disability registry, so that local government and local providers of emergency services and fire and emergency response services are aware of who is where, in terms of the map. And this applies whether it's a rural area or an urban area, and some of the vulnerabilities. If you look at the forms, and some of them are pages and pages, they're very specific about whether assistance is needed, whether a wheelchair is in use, and whether there's any ability to evacuate or not, and what the nature of the disability is. So I think over time, rural communities might be, excuse me, investing more time in developing vulnerable adult registries, or vulnerable person, not necessarily adult registries, to know how to target their response efforts in the event of a mandatory evacuation for an emergency.
Great, thank you so much. Well, we have reached the end of our time together. I want to thank Nancy and Betty for a wonderful presentation today on a really important issue. We will have a recording of the webinar, and the slides will be available on the ASA website and also on the NADRC.acl.gov website. So if you want to view it again or share with others, you can always check out those two websites. And I will just turn it over to Steve for some closing comments.
Thank you.